Presentation by Dr. Bobby Hudson from Medicine 5. Speak without more.
Good morning, everyone. Today, representing Medicine 5, I would like to discuss about speak without a mouth. Presenting Mr. B. Mr. B is a 44-year-old male farmer from Jharkhand who was presented with complaints of fever for the past 6 months, associated with dyspnea on exertion for the past 6 months. Also, he had other complaints of loss of weight and loss of appetite for the past 6 months. The fever was a high-grade fever, intermittent in nature, associated with chills and rigors, and it was associated with cough, which was initially non-productive in nature, and he has took over-the-counter medications, after which his cough has subsided. But coming to the dyspnea on exertion, that was associated with the 2 flight of stairs, he was having a much dyspnea on exertion. There was no associated complaints of any palpitation, syncope, or pedal edema. There was no history of any bone pains or night sweats associated with it. There was no history of any dental procedures or a surgery done in the past. There was no history of any backache associated. Coming to the past history of the patient, he was diagnosed to have a hypertension when he was getting evaluated for the same 6 months ago, and he was given aspirin and atorvastatin medications at a local hospital. Coming to his personal history, he consumes mixed diet and had a normal bowel and bladder habits prior to this episode, but for the past 6 months, he has developed a loss of weight and loss of appetite. Family history-wise, there is no history of any diabetes, asthma, or any cardiac or malignancy in any other family members. So on examination, he was conscious, oriented to time, place, and person, and his blood pressure in the when he first initially presented, it was 120/70 in the right upper arm and 130/70 in the left upper arm. But in the bilateral lower limbs, he had a blood pressure of 180/90 with a pulse rate of 84, and he had a collapsing hemopulse on examination in the at the initial presentation. His respiratory rate was 20 per minute, and he had a normal saturation. Initially, when he presented, his temperature was 98.4. There were no external markers of any infective endocarditis like granulations or Osler's nodes or splinter hemorrhages on examination. His fundus was also examined and was found to be normal. Coming to his cardiovascular examination, his apex was shifted downwards and outwards, but it was in the 5th intercostal space, 2 centimeters lateral to the mid-clavicular line. And on auscultation, he was found to have a early diastolic murmur with a diaphragm of the stethoscope in the secondary aortic area, with the patient leaning forward with breath held in expiration. Other systemic examination was found to be normal. So our clinical syndrome, based after the examination and based on the history, fever associated with dyspnea on exertion, loss of weight, and on auscultation finding an early diastolic murmur in the secondary aortic area. Our initial provisional diagnosis was to consider an underlying infective endocarditis because he had a history of a pyrexia of unknown origin with an aortic regurgitation, and to rule out other causes of the aortic regurgitation secondary to a syphilis or an aortitis or a myxomatous degeneration. So on initial evaluation, we found out that his CBC was normal. He didn't have any underlying seropositivity in him, but we sent a blood cultures and the blood cultures was awaited. So all this evaluation was on the initial OPD, and he was advised for an admission, but the patient was wanted to an OPD basis evaluation. So he went off, and 1 week later, within 5 days, he came to the ED with history of high-grade fever with the dizziness, and at around 3 a.m. he was found to have a deviation of angle of mouth with slurring of speech to the right. And MRI brain acute stroke protocol was done, and it showed multiple small infarcts representative of an embolic phenomenon. And he also had a subarachnoid hemorrhage because of an infarct which underwent a hemorrhagic transformation. So we admitted him for further evaluation, and the blood culture that was sent on OPD basis grew an organism called as Streptococcus salivarius. So this was the initial chest X-ray that the patient had, and we went ahead and as we have already concluded that the patient had an infective endocarditis with an aortic regurgitation, we were looking at the other causes of the infective endocarditis, and we wanted to rule out an aortic valve abscess or a vegetation. So we went ahead and we did an echo also. Echo was not showing any active vegetation, but the aortic valves had a perforated non-coronary curves. And as you can see, the echo also revealed a moderate to severe aortic regurgitation. So we sent 3 more other blood cultures, and all the other blood cultures also grew a Streptococcus celluvaris. So our diagnosis was an infective endocarditis with an aortic regurgitation with Streptococcus celluvaris bacteremia with a septic embolic phenomenon. So we wanted to look into the literature of what is the Streptococcus celluvaris organism and how does it affect and what are the risk factors. These are our questions, and how to distinguish various clinical features and what is the treatment. When we looked about the Streptococcus celluvaris, that is where the name I gave, that speak without a mouth, because it is a normal commensal in our oral cavity and the gut. If you look into the literature, this is most commonly used to make anti-inflammatory properties, because this organism is not actually that virulent to our human body. But and the most commonly, if you look into the causes of an infective endocarditis, it belongs to the Streptococcus viridans family. And the viridans family, Streptococcus accounts for 30 to 40% of the infective endocarditis causative organism. Among that, Streptococcus celluvaris related infective endocarditis is only 5 to 10%. In some studies actually quoted it is less than 2%. The problem with this is whenever you get a Streptococcus celluvaris, as it is a normal commensal, we can actually there's no golden standard to differentiate whether it is a possible contamination or a significant bacteremia. So the most important thing that we noticed in the literature review also, we have to do further blood cultures, and if it has grown in more than 2 blood cultures, then we should consider it as a significant bacteremia, and we should actually treat it. So the Streptococcus celluvaris risk factors is if the patient has an underlying valvular heart disease, or if he has undergone a previous periodontal procedures, or if the patient has a underlying cirrhosis or a malignancy. Why underlying malignancy? Because Streptococcus celluvaris is most closely related to another organism of Streptococcus viridans family, which is called as Streptococcus bovis. Both are very closely related in all the aspects, except that Streptococcus bovis is most commonly associated with causing an underlying colonic malignancy. That is the most reason that can be one of the risk factors, and it is also a part of the normal gut in our body. So, and the clinical features, as we have discussed, the most common thing that Streptococcus celluvaris causes is a bacteremia, and it is more prone to cause a CNS infections. It is more prone to cause a mycotic aneurysm and meningitis. There are multiple case reports where it causes a fatal bacterial pyogenic meningitis. And in patients who are having an underlying cirrhosis or a chronic liver disease, this can also cause a spontaneous bacterial peritonitis. And the treatment for it is a simple treatment. We do a penicillin sensitivity, and based on the penicillin sensitivity, the treatment is to give a ceftriaxone for at least 4 to 6 weeks along with gentamicin to give it a synergistic effect. So in our patient, we started him on intravenous antibiotics according to the sensitivity, but we wanted to go ahead and rule out what is the cause for the septic emboli, where is the source of the, because the echo and the transesophageal echo was also normal. So we did an ultrasound abdomen. Ultrasound abdomen revealed a evolving splenic infarct or an abscess. The radiologists, when we discussed, they were not sure if it was an evolving abscess. So they asked us to go ahead and do a CT thorax abdomen and to rule out any other possible sorts of infection. So we did a CT thorax abdomen that has also showed that the thorax is completely normal, and in the abdomen only the spleen is having in the upper pole some possible evolving abscess. But we tried to reskin it for aspirating it, but it was not amenable because it is still not liquefied. And they were suggested only then follow-up on further follow-up, weekly follow-up. So based on the new 2023 infective endocarditis, according to the International Cardiovascular Society of Infectious Diseases, for the endocarditis, this patient had a fever in the ward. He had more than 100.1 fever, along with a vascular phenomenon, as we can see, and cerebral. He had a septic emboli in the brain, and also he had an evolving splenic abscess. And major criteria that he had was that he had a positive blood cultures. 4 cultures were positive. So this was clearly a case of infective endocarditis with an aortic regurgitation. But the learning points that we wanted to, we did a CT angiogram also, because we wanted to rule out the possibility of a mycotic aneurysm, because Streptococcus celluvaris is more prone to cause among the viridans group to cause a mycotic aneurysm. And that is what has caused the septic emboli in the brain, is what our initial thought process. So we did a CT angiogram. CT angiogram was normal. It didn't reveal any features of a aneurysm when we did with neck to cyclophilus. But when we discussed with the senior radiologist, they said there are features of an intimal thickening and features of an hypertensive intimal thickening in the vessels. So that could be a possibility, is what we have thought. But even without that, Streptococcus celluvaris is not as less virulent as we have thought earlier. And When we checked in our microbiology lab, how frequently do we have this organism infective endocarditis affected with streptococcus? They said we hardly see 4 to 5 cases every year in CMC itself. So so my landing points is, though Streptococcus salivarius is a normal pathogen, whenever we get it as a bacterial growth culture, we need to repeat the blood cultures and make sure that it is not just a contamination. And we also need to make sure that the patient is not missed. Whenever someone presents with a PUO and has a Streptococcus salivarius as a blood culture grown, immediately we should admit that patient and we should not miss that patient, so that we can prevent the further complications arising from the bacteremia. And mycotic aneurysm, the whole possible explanation for the Streptococcus salivarius to cause a mycotic aneurysm, as it seeds within the arterial intima and it causes a neutrophil attraction, and because of that inflammation, it causes an atherosclerotic arterial injury, and that can cause a mycotic aneurysm. These are my learning.